Good morning. Thank you for joining SmartXPD today for a presentation on non-motor Parkinson's symptoms and how they can affect relationships. I'm Patrick Lasasso, president of SmartXPD and coordinator of our Parkinson's Life discussion group. This is a place where we come together to unite, strengthen, and share. If you enjoy SmartXPD, please consider making a contribution. You can find a thanks button to do so on the YouTube channel banner, or there are payment options in your email notifications. We're recording today's presentation, so if you don't want to be seen, please turn off your video and make sure your microphone is muted so we have a nice quiet room. But make sure you know how to unmute if you have questions at the end. You can also enter your questions into the chat as we go, and I'll read them at the appropriate time. We'll email you a link once this presentation is posted to the SmartXPD YouTube channel so that you can view it again and share it with your friends and groups. Today, we're so fortunate to have special guest, Dr. Joanne Hamilton. Dr. Hamilton is a clinical psychologist who specializes in neuropsychology. She focuses on disease that affect older individuals such as Alzheimer's, Parkinson's, and stroke. She works in conjunction with neurologists to provide personalized care plan for every patient. She also evaluates individuals with multiple sclerosis, seizure disorder, and traumatic brain injury. She's passionate about her work, and outside of the office, she enjoys camping, playing pickleball, running, and spending time with family and friends. We're so lucky to have her here with us today. Please give a warm SmartXPD welcome to Dr. Joanne Hamilton. Thank you so much, Joanne.
So today, thank you so much, by the way, for inviting me to speak to you all. I think this is a really important topic. As some of you may have found, when you were first diagnosed with Parkinson's, the neurologist kind of did some motor testing with you, said, well, this looks like Parkinson's disease, gave you a prescription for levodopa carbidopa levodopa, which is Sinemet, and said, see you back in 3 weeks, 3 months if you're lucky. And unfortunately, that doesn't quite get the whole picture of Parkinson's disease. And I think probably in the last 5-10 years, there's become more of an appreciation by those of us who work in this field that Parkinson's affects the entire body, and the motor symptoms are sometimes the least important when it really comes to disability and challenges in relationships. And so I really appreciate the opportunity to talk to you all now about some of the other challenges that occur besides tremor and rigidity and gait changes. I think it's important for you all to understand how these non-motor symptoms impact people who have, what's traditionally been called a motor disease. And it is probably on all of your minds today, what are some of these non-motor symptoms? It may be the case that you've noticed some changes in yourself or your loved ones, and you're trying to figure out, is this Parkinson's or is this something else? I always think it's important to understand how this is impacting you on the day-to-day. And then, of course, to figure out some ways to manage these symptoms, because they are a large contributor to the types of disability that individuals encounter with Parkinson's, and they actually themselves cause the majority of distress for loved ones. So let's think a little bit about why these thinking and behavior changes will occur in Parkinson's. And truthfully, it's the same reason why individuals develop motor changes. There are neurotransmitter systems that are important for managing mood, thinking, behavior, that also contribute to the way a person moves. And when we think about this, it's largely due to the fact that when our brain thinks, it does so through both an electrical signal and a chemical signal. And in Parkinson's disease, the chemical signal that you hear most about is from a neurotransmitter called dopamine. Dopamine is made in cells called the substantia nigra, which are deep in the brainstem of a human brain. In healthy people, the substantia nigra appears black, hence the name substance nigra, substance black. In Parkinson's disease, those cells begin to die. And when they die, they're not able to produce dopamine for the rest of the brain. The substantia nigra has direct communication through its neurochemical tracts with both motor and thinking areas of the brain. And that's where these non-motor symptoms arise, because you're losing dopamine input for both the movement sections of the brain and also the thinking, behaving sections of the brain. Those thinking and behaving sections of the brain include your frontal lobes, which are important for your judgment, for insight, for problem solving and planning, as well as memory systems, which are important for learning new information and being able to retrieve that information over time. You'll also notice that there's some changes in your language systems that are important for word finding and understanding speech. Now, what we find for most people is that not only is the dopamine reduction important when we think about someone's ability to think and behave, but also the fact that replacement medications like your Sinemet, your Maripex, your Requip can also impact thinking and behavior. Sometimes it's for the better by improving the speed in which you think, and sometimes it's for the worse by overstimulating certain parts of the brain that are usually responsible for impulse control or for determining what perceptions are real or what perceptions are false. And so as we talk today, you're going to think about whether the symptoms are being caused by the Parkinson's disease or being caused by the medications to treat the Parkinson's disease. It's not just dopamine, though, in Parkinson's that's important. We also recognize two other neurotransmitters, chemicals, serotonin and acetylcholine, that also play a major role in a person's behavior and in their thinking. So what are these types of problems that are actually very common in Parkinson's? And the list is long. My guess is that the vast majority of folks here, or if they're here for a loved one, that loved one is experiencing at least one of these symptoms. Research has shown that very, very close to 100% of people who have Parkinson's will experience at least one non-motor sign. And usually it's about 8 of these non-motor signs. And those include thinking, so your cognition, your behavior, neuropsychiatric symptoms like mood disorders, apathy, psychosis, which are delusions or hallucinations, impulse control, buying too much, engaging in behaviors that are not typical of you, but become obsessive. Sleep disorders are extremely common in Parkinson's. And there's one in particular I'll talk about right now called REM behavior disorder, which is a disorder of sleep in which you're able to act out your dreams. And REM behavior disorder can occur decades before any motor symptom of Parkinson's shows up. So this might look like an individual who thrashes around while dreaming. We've had folks actually get up out of bed and tackle the nightstand playing football, or attempt to walk downstairs to go out the door as part of a dream. It can be dangerous for a care partner who becomes the antagonist in a dream. We've definitely had spouses punched or kicked as part of these dreams. Insomnia becomes a really common issue in Parkinson's related to some dopamine changes. We also see problems with nighttime awakening, where a person is getting up multiple times a night to use the restroom and then having trouble falling back to sleep. It's not just sleep disorder at night, but a lot of folks with Parkinson's will develop what's called hypersomnia, which is sleeping much of the day. We see these fluctuations in alertness where a person might fall asleep at inappropriate times while eating dinner, certainly while sitting and watching TV or while having a conversation with a group of people. So it's not just the inability to sleep, but also sometimes too much sleep that will affect a person with Parkinson's. Pain disorders are very common, and oftentimes a decade or so before the motor symptoms show up. An individual might start going to orthopedic doctors to figure out why they've got so much pain in their necks or shoulders. And very often it'll end up that individual is diagnosed with Parkinson's within the next few years. Olfactory loss is now a known risk factor for Parkinson's disease. So that's the loss of your sense of smell. And a lot of folks don't even realize they've lost their sense of smell until something important happens. I have a patient who accidentally left the gas on the stove, and thankfully the house didn't blow up, but by the time her husband got home, the entire house was filled with gas. And she wasn't able to smell it, and that was their first indication that something was actually really quite wrong. Autonomic dysfunction is a very common impact of Parkinson's, and it's difficult to understand. So autonomic dysfunction includes everything from urinary symptoms, erectile dysfunction, constipation that can occur, again, decades before you start to see the motor signs of Parkinson's. Hypotension becomes a pretty dangerous symptom that has to be managed. People will oftentimes become faint when they stand up. Their blood pressure doesn't regulate in time, and they'll have a syncopal or a fainting episode. So all of these factors are common non-motor symptoms of Parkinson's disease. And unfortunately, not all physicians will think to ask you about these symptoms. Some of them are quite embarrassing for patients to talk about. And so as an advocate, these are very important issues to bring up with your neurologist. There are some treatments for some of them, but certainly management is important, and they're not always going to think to ask. So if you're experiencing any of these types of symptoms, it's very important to bring that up with your neurologist. Now, let's talk about some of the common behavioral changes. These are going to occur in the majority of people with Parkinson's disease at some point in their disease course. Very often, the mood changes, the depression and the anxiety, those will predate the motor symptoms. So in an individual who's never been prone to anxiety before, all of a sudden there'll be some excessive worry, agitation, even fear. People a lot of times will describe anxiety internally as if like their insides are kind of shaky and they feel unsettled and uneasy. Depression, which we all kind of think about as a sad mood, can become much more intense to the point where it's difficult for a person to experience pleasure or enjoyment in the way that they once did. At its most significant, it can begin to impact a person's ability to just take care of their day-to-day activities, not being able to get themselves to get out of bed, not being able to get themselves to take care of themselves, like take a shower, or engage with friends and family. Psychosis is very troubling for care partners. So in psychosis, you're experiencing stimulus that doesn't exist for the rest of us. So either seeing things or hearing voices that the rest of us can't see or hear, or beginning to have very strong beliefs that the rest of the people around you don't share. Some really typical delusions include the fact that your belief that your spouse might be unfaithful or having affairs. They could be beliefs that people are stealing from you, taking things that don't belong to them. Those are very common delusions in people who have Parkinson's, and they're not uncommon, unfortunately. And so these are certainly aspects of behavior that need to be brought up with a neurologist or a geriatric psychiatrist so that we can begin try to offset them. We'll talk a little bit about what to do if your loved one is experiencing those kinds of symptoms. We see quite a bit of impulse control problems in some individuals, especially those who are taking dopamine agonists like Requip or Mirapex. Those are repetitive behaviors that have become very problematic. Shopping too much, viewing too much pornography, hoarding. And then apathy, that's a little different. And it's difficult to pull apart what apathy versus depression is. So apathy results from an inability of the brain to get you to act, right? So it's not so much that you feel too sad or down to take a shower. It's just that your brain doesn't even alert you to the fact that you should. So someone who's got apathy will have a good time if they're taken to a social engagement, but they'll never initiate that social engagement. That's a little different than a mood depression, where even once they get there, they're not having fun. These are, especially the mood changes, really common, and they can occur years before the motor symptoms. Sometimes they'll overlap, and it's difficult to tell whether it's depression or anxiety. I think anxiety, for the most part, usually impacts my patients more than their depression, because that anxiety is so difficult to manage. The agitation, just feeling always on edge. We talked a little bit about the hallucinations. These usually occur after the onset of the motor symptoms in most people with Parkinson's. It's not uncommon. About 60% will eventually develop some sort of hallucination. Usually starts as kind of a passing sensation that something's there, and then becomes increasingly palpable, if you will, like increasingly clear and vivid. At first, a person usually has some good insight into the fact that nothing's there, but as time goes on, that insight wears away, and a person has more and more difficulty understanding that nothing's there. We also talked a little bit about the delusions. Like I said, less common than hallucinations, but about a little bit less than 1 in 5 will start to develop some of these delusions. And the frequency of the psychosis, of the hallucinations and the delusions, that increases as people are developing worsening thinking problems. So as an individual develops more severe memory loss, more severe executive dysfunction, more severe language problems, they'll also start to have more severe hallucinations if those are part of their clinical plan or their clinical picture. We talked a little bit about the impulse control problems too. These are very important to discuss with your physician, because sometimes they're being driven by medication as opposed to Parkinson's itself. Let's see, I want to make sure that we're understanding these words that doctors oftentimes will use, because I'm going to talk a little bit about the cognitive issues that occur in Parkinson's now. When you or your loved one is noticing some cognitive changes, but your physicians are not, it's not because you're missing the boat. It's because we don't have the tools to necessarily identify the mildest of cognitive changes. Once we can identify them, and we do that through neuropsych testing, which is what I do, you may get a diagnosis that's mild cognitive impairment. And it's a little bit of a misnomer, because it's not necessarily mild, but what it means is that the cognitive impairment isn't so severe that it's already impacting your day-to-day functioning. Once it does become so severe that it's impacting your day-to-day functioning, then the term is dementia or major neurocognitive disorder. And there are many, many causes of dementia. In somebody over 65, Alzheimer's disease is the most common cause, but Parkinson's disease is right there behind it. And unfortunately, what we know now is that the majority of people who have Parkinson's disease will develop dementia or serious cognitive issues at some point in their journey with Parkinson's disease. And it may be at the end of that journey, or it may be earlier on. Folks who have mild cognitive impairment, so definitely measurable, but not as impactful in the day-to-day functioning, usually about 40% will show those sorts of changes early in their disease course. And the types of changes that we notice earliest in most people's disease course are those that affect the front part of the brain, or where the dopamine projections were greatest. And those kinds of problems include executive function, like planning, problem solving, flexibility of thought, ability to organize your intentions, learning, like being able to learn new information, being able to come up with words you want to use easily and fluidly, so that it's not just always stuck. And then problems with emotional control. So some ups and downs, irritability, frustration, maybe some tearfulness. In other folks who have Parkinson's disease, we'll start to see earlier on these changes in spatial awareness, in visual processing, and in rapid forgetting, memory issues. Unfortunately, these are the folks that will oftentimes develop more serious cognitive issues earlier in their disease course. They're also the ones that will oftentimes develop hallucinations earlier in their disease course. And so we want to think about, how are these things going to affect a person's day-to-day functioning? Well, the good news is, even though executive dysfunction and problems with learning oftentimes will appear early in the course of Parkinson's, they are typically fairly stable. They don't necessarily become associated with that more severe cognitive loss called dementia. Like I said, those who start with problems from the back part of their brain, their visual awareness, have a tendency to be at much higher risk for falling and for having visual hallucinations. And they tend to have a much more significant decline in their thinking overall. They tend to be a little bit more, I should say, the use of acetylcholine replacement medications like Aricept, donepezil, or Exelon tend to work better for these types of folks than they do for people with the more frontal changes in their thinking. Oops, wrong way. There we go. So when we think about how these changes impact a person, we think about executive functions and what needs to be done to help with those. I always say, hey, listen, kind of pay attention to where some of the struggles are, and then really try to help break these tasks down in step by step. You want to make the world as decluttered as possible, because it's hard to think flexibly if you have a lot of different things going on. So you want to use strategies that will help a person focus on one aspect of their task at a time. Try not to multitask. None of us are actually good at multitasking. All we do is we sort of jump from one thing to another. And some of us jump fast enough to get back before we've forgotten what we were doing. But that, for every person as we get older, goes away. And so if you can avoid multitasking and just do one thing at a time, it's beneficial. Watch for changes in alertness. So there will be times throughout the day where thinking is clearer. Do the important things during those times. I find that most individuals with Parkinson's have a rough time getting up early in the morning for appointments, because it takes so long for the dopaminergic agents, the carbidopa, levodopa, to actually start working. Usually they're doing best between about maybe 10 to about 2. And then anything after 2, fatigue has set in. And that's just going to increase the rates of frustration and irritability, because none of us want to be out there, doing important things when we're physically exhausted, not sleepy, but exhausted. If there is a lot of forgetfulness, be sure to use your phone wisely for lists and reminders and alarms. There are a number of different really helpful techniques that you can use. Everything from pill boxes that have a little alarm setting on them, down to medication dispensers that can help keep up with the very complicated regimen that is Parkinson's disease medications. If you're noticing yourself or your loved one starting to fall more, analyze what the environment looks like. If there are rugs in the way or cords or too much furniture in one small spot, really think about opening corridors and making it an easier place to walk. A lot of folks with Parkinson's will develop some freezing gait where when they stand up to try to move, their feet get stuck. And there's some studies that show that by putting marks, even with tape on the floor that give the eyes a target to move towards, it can help manage that freezing. Work closely with your physician for some physical therapy on that, because some of those gait issues can be retrained. A lot of my patients become very frustrated by the fact that they feel like they're losing their independence and that their typical tasks are being taken from them. And what I try to encourage folks to realize is that, you only have so much bandwidth. And if the bulk of the bandwidth is being taken up by mundane tasks, making dinner or, paying bills, you're using up a lot of the energy that you would normally have in order to enjoy life. So really think about the idea that holding on to these mundane pieces of your life is actually taking up time from more important ones. Focus on things that could be meaningful. A lot of folks feel embarrassed or inefficient when they're experiencing depression, anxiety, and unfortunately, there's still a stigma. There, we're still told, well, just think happy thoughts and pull yourself up by your bootstraps. That doesn't work. So we should stop thinking that it does. Talk to someone if you're starting to experience signs of depression, anxiety. If your care partner is noticing that you're beginning to engage with perceptions that no one else sees or hears or experiences, bring that up to your physician. These are not symptoms that you should suffer with. They're not embarrassing. They're part of this disease. We talked a lot about impulse control problems. These are absolutely something you must talk to your physician about. With apathy, it oftentimes will take external support to overcome that apathy. That's something that's occurring because the brain is not working correctly, not because you don't enjoy your time. Use routine, have a walking partner who comes by and picks you up at a certain time every day, and then stick with the structure, stick with the schedule. Okay. I cannot stress how important exercise is. I want you to think of exercise as medicine for Parkinson's and for the caregivers who love the person with Parkinson's. It is beneficial for your mood, for your thinking, and for your movement. There isn't a way to understate the importance of exercise when it comes to Parkinson's. When you're dealing with cognitive issues, again, you want to limit the distractions. Consider the fact that every distraction is one less point of bandwidth that a person has. So you want to break all those projects down into smaller pieces and just tackle them one at a time. You'll notice much less frustration, much less upset in life. Recognize what is pushing some of these emotional symptoms. So if a person is beginning to feel a little bit anxious and panicky when they have to go into big crowds, start to notice what that's about. Talk talk with your loved ones, talk with somebody who is trusted, and begin to really break down what's part of those emotional issues. It will help with intimacy, and it'll help reduce some of the anxiety. And of course, all of us, care partners, individuals managing Parkinson's, your doctors, we all benefit for some of these techniques. This is self-care. And I tell all of my care partners and individuals managing with Parkinson's, you're not going to be good to anyone if you're sick yourself. And so please consider some of these self-care techniques as you're moving forward in your journey. And then, of course, did I mention exercise is a medicine? And for those of you who are suffering from some of the emotional challenges that are part of Parkinson's, there's a website, it's psychologytoday.com, and you can find a listing of professionals who will specialize in those challenges. Take care of yourself as you're moving through this journey. All right, I want to leave plenty of time for questions.
Oh my gosh, Joanne, thank you so much. This was excellent. I want to make the offer, because some of the subject matter, if someone has a question that they're embarrassed about asking, maybe to the whole group, if you want to message me directly, if you typed it into the chat and send me, I'm not going to be, usually I say, oh, Sharon has a question, it's this. I'm not going to be mentioning any names today. If you have a question that you don't feel like comfortable asking in front of the group and you'd like to send it to me individually, I'll ask it for you. That being said, I just wanted to toss it out. If you have a question, you can raise your hand, or you can just virtually raise your hand or take yourself off of mute and ask. But Joanne, I want to thank you so much. This was such an important conversation. And I was kind of taking notes here on some of the stuff that you've really identified that sometimes in our community goes without being noticed, specifically the care partner side of it, that Parkinson's really affects the whole family. And if you're a care partner, you need to take care of yourself as well. And it requires systematic and programmatic approach to it. You have to be, like Joanne presented here, you have to think about how to do this. Let me see here. Okay, please. Okay, so this is a question for neuropsychologists in LA that take Medicare. If you email me offline, I will put you in touch with a resource for that. And incidentally, if anybody needs resources in the LA area, I'm involved with a nonprofit called Parkinson's Community Los Angeles, and we're really good at finding resources for you. Okay. Oh, so that's a resource right there. Is Joshua in LA?
Yeah, he's in Northern Orange County.
Okay.
UCLA has some great providers. It's a little hard to get in. Keep in mind, neuropsychologists, there's not as many of us as there are regular clinical psychologists. So it's a little tricky, but what I would do is when you call, and you can look up that website too, psychologytoday.com. When you call, ask specifically if the individual specializes in neuropsychology and the treatment of older adults. That usually will get you into that side of things.
Okay, great advice.
Okay, I got a great question. How can you tell if these symptoms are Parkinson's, something else, or nothing? Most likely, if you're asking me that question, it's not nothing. And I think it is an important point because unfortunately Parkinson's is all encompassing. Everything can be chalked up to Parkinson's, and it's not always. So that's where your medical doctor or your psychologist can be very helpful. All of us have relationships. We had them before we ended up with Parkinson's, and it may be that some of the depression or the anxiety is actually stemming from past experiences. What I would say is that if the symptoms seem to get worse in a similar pattern as your on-off, it's probably Parkinson's. So a lot of times what we'll notice is, when a person is off, meaning that their medications aren't controlling their motor symptoms, we actually see an increase in the non-motor symptoms. And that gives us a really strong indication that we're probably dealing with symptoms associated with Parkinson's.
Is that consistent as well with, would you might see an exacerbation of these types of non-motor symptoms due to lack of good sleep or stress?
Yes, exactly. So all of you probably notice that when you're under stress, your tremor is much worse. Or when you're under stress, your word finding is much worse. There's no better way to bring out word finding problems than to ask somebody to give me all the words you can think of in a minute. Boy, all of a sudden there's a lot of word finding problems. That's because stress is a physiological issue, right? We experience stress kind of emotionally. Oh, I'm nervous, I'm a little keyed up. Your body is experiencing it physiologically. It's experiencing it by an increase in the autonomic nervous system's sympathetic side. So you're going to have shorter breath. Your heart rate's increasing. You might feel a little bit clammy. And all of the physiological things that are happening during that autonomic system overload also impacts the way that your brain can think. And so tremor does get worse. Word finding problems will be worse. Confusion is most definitely worse. And all of those things result in greater fatigue.
Okay, I'm gonna give an opportunity for someone else to jump in here, but I also have a question in the meantime. So someone experiencing mild cognitive impairment, do they typically, I mean, I hear this, that's one of the more common things I hear. Do they try to manage that with medication or with certain cognitive exercises or a combination? If someone's experiencing that, what can they expect to do to address it?
The first thing I do is talk to the neurologist, make sure that that you're not on too high of a dose of carbidopa-levodopa. So sometimes, Parkinson's is a tough one, right? There's a sweet spot, and that sweet spot stays around for a year maybe, and then there's a different sweet spot, and then there's another sweet spot. So if you're on too much of those drugs, sometimes we'll see confusion, cloudiness. People will describe kind of a fog that's over their mind. So first, if you're feeling mild, that there's some symptoms of mild cognitive impairment, talk to your neurologist. There's not a lot of evidence that the medications will necessarily help in mild cognitive impairment. But a lot of anecdotal evidence, at least, suggests that some of those medications that are prescribed for Alzheimer's disease, like the donepezil and the Exelon, rivastigmine, may work better in Parkinson's disease. There seems to be possibly even more acetylcholine dysfunction in Parkinson's. So those are definitely conversations with the neurologist, and medication can be beneficial. Behaviorally, what you're looking to do is make sure you're not on any medications that have strong anticholinergic properties. Some of them have to be those medications for reasons, but the extent that you can avoid like Benadryl, avoid certain medications for your bladder, diazepam, if you can, because those types of drugs can increase the level of fogginess that a person might experience. There are other behavioral changes. You want to arrange the house for success. So try to use all the techniques that we now have available to us, our phones, the to-do lists, the calendars and such, to help remind you of the things that you need to be doing. And then, of course, manage mood, because that can cause worsening thinking, and exercise. Exercise.
Sorry,
Exercise. Um,
we're having a little audio issue from your side. You had, what were the two things? Movement, manage your mood, or movement?
Manage your food, your sleep,
Oh, okay.
and exercise.
Okay. Is walking considered the best exercise for Parkinson's because you have to think about where you are going, where you step, gait, etc.?
So walking is a great exercise for Parkinson's. Also, rock steady boxing. That's been shown to be a fantastic exercise. The idea is that you want to do exercises that are going to pair movement with thinking, timing. So the reason rock steady boxing is beneficial is because there's a lot of timing in rock steady boxing. Tandem cycling, same thing. There's a lot of timing in tandem bicycling. So truthfully, I'll take any exercise. There's no right exercise. But walking, biking, rock steady boxing, those are all great.
Yeah, I loved how you had that in your presentation. I hadn't seen that before, non-contact boxing. And I think, you know, as an exercise guy, I'm always just talking about boxing, assuming everybody knows they're not going to get hit in the head. It's an important clarification. George, go ahead.
Yes, it's very timely because you know, I went down and wrote down a lot of the things that you said. Can you hear me all right?
Yeah,
definitely.
great.
Because I was looking down through the cognitive, again, I find from time to time that I can't find the right word. Earlier we were talking here, I couldn't get the right word out. And also maybe I watched something last night and we're watching it tonight. My wife says, do you remember that? I may not remember it. And then there's things such as the smell. That's an issue. And the mood changes, anxiety, I think that could be a big problem if I'm not careful, because there's always something that seems to be worried about. And I try to work on that, try to be mindful and rest and try to focus on something else and try to get around it. And the other thing was, and so what I'm saying is, these are things that you mentioned and brought up, that since I'm seeing my specialist, a neurologist tomorrow, why these are topics that I can discuss with him. So it's very timely. So I appreciate it. And thank you.
Good.
George,
Good. I'm glad to hear that.
George is our resident bass vocalist, as you can hear.
I can hear it.
Yeah,
That actually reminds me, do you all know of tremble clefs?
Yes, most of us know about them. Yeah, we've had some speech pathologists come in to talk to us, and that has come up. But did you have something more to say about them? They're awesome.
No, they're fantastic, and it reminds me, you know, when we're thinking about the behavioral techniques for managing symptoms of Parkinson's, it's really easy for, you know, your doctors to give all these ideas, and that's fantastic, but they have to be ideas that are going to resonate and stick with you. So think about the fact that there may be some things you've always really loved to do. Problem solve and decide if there's a way that you can incorporate that thing into behaviors that help you. So if you're a singer, tremble clefs is perfect. If you just enjoy music, tremble clefs is perfect. But if that makes you so anxious that each morning before it's time to go, you're you know, crazy, can't get any words out, then that might not be the thing for you. Maybe instead, you know, reading out loud with a book is better. So think about that. It's not one size fit all. While everyone with Parkinson's will experience some type of non-motor symptom, it's not the same for everyone. There are very few diseases that is so variable as Parkinson's.
So I'm just going to read this because I want to make sure everybody hears it in the chat. And then Joanna answered it. How much exercise? How long per day? So Joanna answered 30 minutes, 5 days per week, and enough to get your heart rate up. And that is absolutely consistent with the American College of Sports Medicine, which just came out for a prescription for exercise for Parkinson's in their 11th edition. And it recommends exactly that, 30 minutes. They say 70% heart rate or above for 30 minutes, 5 times a day. That may be way too much for many of us, but that is a great recommendation. 5 times a day, 30 minutes. I love the way you put that, enough to get your heart rate up. And I'll just share with you, we had, Joanne, I had a question in one of our classes, which would never have occurred to me. And this student asked, what should we be doing on our off days, on the days we don't exercise? And I'm like, that's an awesome question. So, I'm putting together some routines for off day work, because really I think it's good for us to be working on this every day, even if it's 3 to 5 minutes on the off days, with something that makes.
I think what you'll find once you start to get into exercise, that if you don't, you will know it. You will move slower. You will move with less agility. And you will feel it in the same way you feel yourself going off when your drugs are not working well. I want to say, it's easy for me to say 30 minutes a day, 5 days a week, right? But if you're not somebody who's ever exercised, or if it's been a long time since you've exercised, then that's a daunting task that will be impossible to overcome, and you won't even start. So instead, if this is new to you, do 3 minutes today, and 3 minutes tomorrow, and 3 minutes the next day. And then after that, add and make it 5, and then add and make it 7, and then add and make it 10. There's no perfect way to do this, but once you start, you will notice when you do it. It'll make a difference.
Yeah, and that has come up quite a bit with our community, where people encounter an injury or something takes them away from them to be able to do their exercise. And I hear it all the time. People come back and they say, I need to exercise. I can feel it. So that's a really great example. I want to get to this question. When sleepy all day, is it good to do more movement, or better not to take a nap?
Take a nap. So I recommend to folks with Parkinson's, take a 20-30 minute nap after lunch. Even if you're not a nappy type person, sit down in a quiet place and do a meditation. You need to rejuvenate the energy levels, and you'll find that you're sharper in the later afternoon if you allow your brain to rebuild, to recover from the morning. You don't want to let your naps go much longer than about a sleep cycle, about that 20-30 minutes or so, because once you start to go too long, and if you allow yourself into a deep sleep, a lot of times folks will feel kind of confused and fuzzy when they wake up, and they may start to impact their nighttime routine.
That's great advice. So putting a limit on your nap, but I'm sure everybody was happy to hear that napping was recommended. So let's see, we're nearing the top of the hour. But I do, let me ask this question, because it occurred to me, as you were talking about this nap and this managed nap, are there any types of like meditation applications or like, smartphone applications that you've heard people benefit from? I know I use a sleep app to put me down, a meditation app that I've tried. So do you have any thoughts on that, or have you encountered that as an issue?
Yeah, I have no stake in this company, but I use an app called Balance. I use it every day. It's put together with based on principles of mindfulness-based stress reduction, which sounds like psychobabble, but in reality, it's an empirically validated treatment for anxiety disorders. It's been remarkably beneficial for my own sleep. The little modules are very easy to follow, maybe 5 minutes, maybe 10 minutes maximum. And the important thing about the practice of meditation is that it offsets the fight or flight system. So in our autonomic nervous systems, we have fight or flight, which is when you're under stress and you're going to escape from a bear. So your heart rate goes up, your breathing rate gets more shallow, blood gets shunt from your brain down to your important organs and your muscles. You don't think very clearly because who wants to be remembering that they're being eaten by a bear, right? You know, historically and in our evolution, it was awesome because it kept us from being eaten by a bear. And now, because we spend most of our time in that sort of fight or flight system, because traffic stinks, and now I'm late for work, and now my patient's mad, and et cetera, we burn out that stress system. The other side is the parasympathetic nervous system, and that's the side that recovers the body. That's the side that brings the heart back down and lowers the blood pressure and turns on the gut and turns on the sleep cycle and turns on the immune system and lets us think. And none of us really spend any time in that one because we're always being eaten by a bear. And so the meditations and the mindfulness-based stress reduction teach you techniques that allow that side of the brain to do its job. And that's why they're so important.
Love it. You know, at the World Parkinson Congress, I think this last time I wasn't there, but I heard there's a lot of technology out there available to make things better that if it hasn't been released yet are down in the pipeline. And I think the taking advantage of all these apps, like you just suggested, Balance, is can really help what our objective is here, which is to optimize our quality of life.
Is that the name of the app, Balance?
Yes, I believe that's yes. The name of the application is Balance. I want to give a chance for one more question here. She just typed that into the chat, and if not, one of the real common issues I hear from care partners is the apathy issue for their partner. They're trying to get them to do stuff. In my case, it's mostly they're trying to get them to exercise. If folks are feeling apathy out here, what is like your first go-to advice, your first line of defense to kind of combat the apathy?
Structure, group exercise programs. So sometimes even me, I don't wanna, I just don't have the, but if you know you're beholden to someone else, you have a trainer who you've paid money to, who will arrive, come or hotter in 5 minutes, all of a sudden, I'm ready to go, right? Do not expect that you'll be able to rationalize, plead, bribe someone out of apathy. Apathy literally requires help in overcoming the inertia. And that help can be with, tribe. Like maybe every day a different friend comes and it's time for us to go for our evening walk. And once it becomes a little bit more of a routine, sometimes you don't need that friend anymore, but you probably are still going to need that friend.
I love it. That's a great recommendation. Joanne, thank you so much. This is inspiring. And thank you to all in the SmartXPD community who've joined us today. Remember, once this presentation is uploaded, we'll be sending a shareable link. If you enjoy SmartXPD's presentations, please consider making a contribution. You can find a way to do so in the YouTubes. And if you're watching this in the emails, and if you're watching this in YouTube, there's a thanks button you can put as well.